Good evening, ladies and gentlemen, dear colleagues. You are all welcome to today's workshop. We're going to be looking at clinical reasoning and clinical decision making. Before we start, I think the slides, I'm going to just share a template for clerking. Because as we go through the slides, I'll be referring to the process of components of patient management. For those that were with us during the workshop on evidence-based practice, we dwelt a lot on the components of patient management. That's looking at examination, the assessments that we do, the observations, the tests that we do, all that is part of the clerking process is considered as examination, but all the results that we take, we evaluate, we interpret, so that we can be able to make a diagnosis. So part of the clerking process is to collect data as we observe patients, as we assess them, or be it subjective, objective, as we wish to call it. But whatever data we collect, we interpret, then we reach a diagnosis. Then after the diagnosis, we set prognosis for patients, and then we decide what interventions to give based on the assessment and the interpretations that we did during the clerking process. So these are the 5 components. Of course, the 6th one is we are looking at what we have done in the clinic, how does it impact on the patient's life as they go out into the communities and get integrated back into the society. So when we talk of clinical reasoning, we are talking of the thoughts that come to your mind as you are doing the assessments, making the decisions on what the prognosis is. Of course, that part of evaluation or interpretation of the examination results is also something that requires a lot of clinical reasoning, a lot of it. And that is what leads to a prognosis, the diagnosis, sorry. The prognosis also is something that requires a lot of thinking. And the clinical reasoning is a lot in that aspect. And also, we know rehabilitation is an active science. What that means is that our thoughts are not just rigorous when we are trying to make a diagnosis. That's why our profession is different from that of other professions like the medical profession, where you have much more rigorous thinking and clinical reasoning at the point of making a diagnosis. By the time you make the diagnosis, usually you know what drugs to give, and that drug can apply to as many patients as possible. But with rehabilitation, it deals with the uniqueness of individuals, considering their environments and their peculiar type of activities of daily living. And therefore, you need a lot of thoughts going into that, a lot of clinical reasoning to be able to know for this patient that has this environmental situation and this other patient that has a different environmental situation, how do I rehabilitate them to be able to make sure at the end of the day, they get integrated back into the society. So this also requires a lot of thinking, a lot of clinical reasoning. So the clinical reasoning is going to apply across all the 6 components of patient management. And therefore, that's why I want to share this. The first thing I'm going to share is a document It's a template by American Physical Therapy Association. They came up with a template for assessing patients. And although there could be other models, but I just use this because with DPT now, we are looking at first contact practice. So I'm going to explain what I mean by that and the reason why I'm using the American Physical Therapy Association template. Of course, we all know that in the United States, you can't practice without a DPT. And therefore, so Nigeria, that we have gotten approval and we'll be moving towards that because the board has said by 2030, everyone must have a DPT to practice. I was in the NUC last week, submitted a letter to the executive secretary. I had a discussion with the academic planning, director of academic planning, and I proposed to them that instead of waiting until students get to 500 level before those that want to do transitional DPT join them, it's going to take very long before people transit. And I told them that why not separate the two programs so that the entry level will run and the transitional will also run at the same time, so that everyone can join every university to do their transitional. And the director of academic planning said it's a good idea, and they are always happy to receive such kind of requests from regulatory bodies. And he advised that I write. So I wrote, submitted to the ES, and I'm going to follow up by next week. Hopefully, in the next few weeks, we might get approval that all universities should start. So the fact that Nigeria is also moving towards the model of the United States, I thought I would use this template. And I will explain a little bit, not deeply because we don't have enough time, why they use the template in the way it is, which is different from what we have. And just very quickly, anything you do in your assessment of patients, apart from the name of the patient, any other thing, you must think of how that can help you to narrow down towards having a diagnosis. And let's not forget that the diagnosis we make as physiotherapists is, and I don't know if there is anyone that is not a physiotherapist on this platform, please help post on the chat forum so that we'll be able to know how to move forward with examples and things like that. So, but before I get those messages, I will, because I know many physiotherapists, more physiotherapists join than other professionals. So I'm going to assume that my examples are going to be based on the physiotherapy profession. So whatever information you collect, you must think of how that information will help you towards reaching a diagnosis. That's number one. This is what is called diagnostic reasoning. You are thinking of how that information is going to help you to reach a diagnosis. Of course, physical diagnosis. And I'm going to show you at some point in this document what a physical diagnosis is. I think on Saturday, this coming Saturday and the upper one, we are going to be looking at systems review. And that is where I'm going to expand more in the explanations on the difference between medical diagnosis and physical diagnosis, and how do we make physical diagnosis, how do we suspect that a medical diagnosis may be present. Instead of us going ahead to make the medical diagnosis, we'll just look at red flags. And when we see the red flags, we'll then refer to a physician. But if we see signs, or at least we suspect that there is a movement impairment, then we go ahead and make a physical diagnosis. So in the process of making a physical diagnosis, or in the process of suspecting that there is an organic pathology that warrants a referral to a physician, we are going to collect data. And as we assess, we collect the data, our brain thinks of how do we make use of this data to make that physical diagnosis, or how do we make use of this data to suspect the presence of an organic pathology so that we can refer. This is what clinical reasoning is all about. The decision we take that this is this diagnosis. That is the decision making. The decision we make that this is not a movement impairment, it is an organic pathology that needs to be referred. This is a decision. And that is what is called clinical decision making. But what prompts the decision? It is the thinking, it is the reasoning. It is looking at this data that we collect and we think about it. And then we make use of it in making the decision. So this is what clinical reasoning and decision making is all about. And as I've said, if your thought is about establishing a diagnosis, or your thought is about suspecting that the diagnosis is medical diagnosis, not physical diagnosis, for you to refer, all this is called diagnostic reasoning. But if your thought is about, I collect this data, how do I make use of it to plan a unique treatment for this patient, as opposed to the last patient that I saw that had different environmental and individual situation? So you are thinking of the data that you collected, but not for the purpose of making a diagnosis, for the purpose of reasoning. So there's a difference between diagnostic reasoning and narrative reasoning. Diagnostic reasoning, you are collecting the data and you are thinking of how to use it to make a diagnosis. Narrative reasoning, you are asking questions, you are collecting data, you are assessing the patient, but you are using it and thinking of how to use it to plan treatment for the patient. So we're going to see the difference as we go through this template. As I've said earlier, it's only the name of the patient that you just keep for record purpose, or patient ID. You can see patient ID. I don't know if you can see this template that says documentation template for physical therapist, patient/client management. So you have the date, you have the patient ID. It is only that patient ID and the name of the patient that are for the purpose of record keeping, just to identify the patient. But any other thing that you have there is going to help you towards either making a diagnosis or planning treatment for the patient. For example, we have the next, which is street address. And we know part of risk factors of diseases is where they live. People that live in areas that have toxins, they would be at risk of having some particular type of diseases. People that, so all depending on where you live, you could be at risk of having some diseases. But how do you get to know this information? If you go back to medical textbooks, you will see all conditions have their risk factors, symptoms, and signs of diseases. So that is what will be coming to your mind. That book that I read says if you live in this type of environment, you will be at risk of having this type of diseases. And your thought is now going back to the books that you read, or it's going back to a class that you attended and a lecture that you listened to, or whatever it is. So these are the kind of thoughts that are called analytical cognitive processes. Thoughts that come from going back to books, going back to listening to lectures, going back to looking at pictures or videos. All these are called analytical cognitive processes. We are going to see that in the slides. That's different from what is called non-analytical cognitive process, that by doing things, if you remember in evidence-based practice, we talked about practice-generated knowledge. So this is not knowledge from the book. This knowledge after you have applied, you see what you have applied. You then apply in another patient. So your thought will not be going back to the books that you read or the article in the journal that you read. You are going back now to the last patient that you saw to say that, oh, look, when that patient came, he also lived in so place. And at the end, we diagnosed that he had so condition. And therefore, this patient is also coming with a similar case. Your thought is going back to the experience that you have had, not the books that you have read. And that is what is called non-analytical cognitive process. So can you see that as you are collecting the data, just asking the patient where they live, you are thinking, and your thought is about how can this information help me to be able to determine what the patient's problem is. Date of birth. Go back to textbooks. You see that the age of the patient could place them at risk of having some conditions. The higher the age, the more you think of cardiovascular, neurological conditions. The lower the age, the more you think of musculoskeletal problems. Gender, females are more prone to having cardiovascular diseases. Males are more prone to having musculoskeletal injuries. So all this, as you are collecting that information, you are thinking. But at this point in the clerking process, you are not thinking of individual conditions. You are thinking more of the systems, because many of these items that are here that you assess, mostly you don't suspect conditions because they apply to many conditions within a particular system. That is why you're suspecting more of the system of the body, cardiovascular system, neurological system, musculoskeletal system, and so on and so forth. Because it is an APTA template, there are some things there that may not be very relevant to us, or it will be different from what we have here. Handedness. We all know there are in some people, there's a part of the brain that handles a particular situation of the patient or activity, and the other part of the brain in other people. So this handedness is important to ask about the patient. Type of insurance, as I've said, issue of Medicare and Medicaid is not something that we have here, and therefore it's not relevant. But when we look at risk, we know the race of the person could be a risk factor for them to be more predisposed to a particular condition, or that's so therefore we know, for example, stroke. They say African Americans are more, or Black or Africans are more at risk. So these are some of the things that you collect and you think about how it helps you to be so. But things like language. So it's about when I come to treat the patient. So when I'm treating the patient, how does it limit my ability to communicate with the patient, and things like that. So you take this information so that you're able to know that would you need an interpreter? How do you communicate? How do you convince people if you don't really understand the language that they speak? And therefore, instead of diagnostic, this may serve more as a narrative reasoning, the thought that will come to your mind. But of course, someone might say it has also a diagnostic implication, but that's the thinking. You just have to think on which of the two aspects is your thought going to drive towards. The education of the patient, when we are talking of especially communicable diseases, the higher the education of the person, the more they are aware of diseases and how to prevent them. And therefore, those that have lower level of education could be more at risk of having such diseases that require knowledge to prevent them. Social history. So this now part of the social history, knowing the customs or religious beliefs or wishes that might affect care. So this is narrative reasoning. This is not about diagnostic reasoning. It's more of narrative reasoning from the way I look at it. With whom do you live? Alone? With spouse? This is also a narrative reasoning, because you want to know who is the support, or who form the support system of the individual. If you want to train them on something and you want someone to help them at home, who will be available? If you want to explain things to people that stay with the patient, and if you want to now even ask them, what was their situation at home? So this is the support system of the individual. More towards narrative reasoning. Advanced directive, this is something that relates to them. Who referred you to the physiotherapist? Well, the person that refers can give an indication of what the medical diagnosis is. So if, for example, the person says case it's a cardiologist that referred to me, I should be thinking of an involvement of the cardiovascular system. So if the study is a pulmonologist that referred to the physiotherapist, we know we should be thinking of the lungs. If it is an orthopedic surgeon that referred, we know we should be suspecting and thinking that possibly there is a musculoskeletal problem. So employment, work, job, school, play. The type of job, it could be a diagnostic reasoning or a narrative reasoning. A driver that sits for many hours driving could be predisposed to having low back pain. An officer that sits looking at a computer for a very long period may be predisposed to having neck pain. Someone that works in a factory where there are emissions could be predisposed to having cardiovascular or cardiopulmonary problems. So all this could be a narrative reasoning, thinking towards what system of the body is affected. Is it ergonomics? We say musculoskeletal. Is it the environment, toxins and emissions? We're thinking of maybe cardio, pulmonary, so things like that. But on the other hand, it could be a narrative reasoning. We are thinking of the type of job of the person, so that by the time we finish treating the impairment, the patient at the impairment level, we want to now know what activities are important to the patient so that we can be able to put them through rehabilitation to get back and get integrated back into their employment before that they used to do before. The living environment. Are there stairs, any railings, any elevators, any ramps? Is there any uneven terrain? This is a narrative reasoning. You are not using this to think of what the condition of the patient is, but well, you can think. This clinical is reasoning. Maybe there might be something that will indicate what the problem is, and things like that. Maybe if there is a gutter that's too wide, and when crossing it, you have to overstretch. So patient has a pain in the groin, asking about the living environment, you give an indication of what might be a possible cause. But then I would think this more from the narrative reasoning perspective, looking at the patient's training and rehabilitation. What should it consider? If he lives in an upstairs, then you need to train the patient on how to climb stairs. And that is why we have these stairs in our gyms. It's not just for the purpose of doing exercise, you step up and you step down. No, it's for the purpose of activity training. Let's train the patient on how to climb the stairs to be able to go up to where their room is upstairs. If there are ramps, if there are uneven terrain, let our balance exercises involve the use of the actual uneven terrain in the patient's environment, so that at the end of the day, we'll be able to know how to navigate them, not the ones that we use for them in the clinic, making assumptions that that's the uneven terrain they have. They will train on the uneven terrain you give them in the lab or in the clinic, but when they go back home, they will have difficulty still navigating the uneven terrain that is in their own environment. So ask them, what are the uneven terrains that you have? What assistive devices do you use? Should we continue to use them? No, should we keep them? And because they can have recovery, why should we continue to use the assistive devices that will stop them from recovering and make them to go through compensation? So these are the issues. Where do you live? Private home, private apartment, rented room, board and care. So this is not going to be for diagnostic reasoning. It's going to be more of narrative reasoning. Then the general health of the patient, and then social and health habits. This is also part of social history. Smoking. Do you currently smoke? If it's a yes, it doesn't mean that the patient will be at risk. Not at all. I smoke one stick every day. I may not be at risk. I smoke 20 sticks in a day, but only once in 2 or 3 weeks. I may not be at risk. So risk factors, if you now go back to the evidence-based practice lectures that we had, you'll remember that we talked about the evidence that we get from case control studies. And I gave an example with smoking of how you look at smokers and non-smokers, follow them and see who developed the condition and who doesn't develop the condition. Usually in those kind of studies, They are going to tell you that it's not just that someone smokes. Even out of those that smoke, it is only those that smoke up to, say, 5 or 10 sticks per day for many days that develop the condition. Not everyone that smokes. So the same thing if someone says, I don't smoke, your thought should not just go into thinking he's at risk of having a cardiovascular disease or any other disease. You will think, you'll still have to ask a follow-up question. When last sorry, he said, I don't smoke. Or does it mean you have never smoked? No, 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 no. I smoked in the past. How long since you stopped? 1 month or 2 months? The patient may still be at risk. Researchers have shown that it is when the patient has stopped smoking for over 6 months that you can, you may not see them as being at risk of having such conditions. The same thing will apply to alcohol intake. So do you take alcohol? If it's a yes, there must be a follow-up question. How many cups or whatever it is that they use, or bottles of cup per day? And also if they say we don't smoke, when last did you smoke, and things like that. So this is clinical reasoning. This is helping you to be able to bring out something that is meaningful. And as we are thinking, all these things that we are doing, we are interpreting. Therefore, it's part of evaluation. Just asking the patient, do you smoke? Yes. It's not enough. You have to now interpret. So that's part of also clinical reasoning, the evaluation process. Next is exercise. Do you exercise beyond normal daily activities? So just that, do you move around? You say yes. You say, okay, this is no. I think we as physiotherapists, we should know that when we ask that question, there must be a follow-up question. What's the intensity? Is it just slow walking? Do you run or do you jog? How fast is it that you move? And for how long? Up to 30 minutes, up to 10 minutes, up to 1 hour? And for how many days in a week? Up to 3 days, 4 days, or 5 days? So that is what is going to now interpret. And that's part of interpretation. And that's thinking. And that's clinical reasoning. Then you go to family history. You ask the patient whether they have had heart disease, hepatitis, their family, primary family, mother, father, brother, sister, aunt, uncle, or grandparents, if they have had any of this, and then you leave an open-ended question: is there any other condition in your family? So what is this? This is about genetics of people, that their parents have a condition that is genetically inclined. They also might be at risk of having such, and that is what is the thought in your mind. And then the medical history. What sorts of medical history have they had? Someone that has had pneumonia as a child may be prone to having bronchitis as an adult. This is a medical or surgical history. So for women, always ask, have you been diagnosed with pelvic inflammatory disease, endometriosis, trouble with your period, and things like that. These are related to females. And for males, you ask about prostate and things that are relevant to men. It is only when you have asked all these things. And that is why I said this template is different from the one that we use. When I teach, our students will always complain to me that, wow, what you are asking us to do is going to be a very big trouble for us when we go to the clinic. Because what we are used to is that when the patient comes and we check the name and we just straight away ask them, what is your current condition? What is your chief complaint? And therefore, for us now to begin to ask the patient, and it's only when we get to item number 23 that we ask them the current conditions, we'll have two problems. Number one, our supervisors are going to fight with us and say that that's not the norm in the department. While our patients are going to think that, why should I waste my time coming to see this person, and he's going to continue to ask me irrelevant questions until we get to number 23. But then, from both sides, in the past, we did BSc PT. That's what I did. We know what BSc PT does to you. It doesn't make you to serve as a first contact practitioner. The patient must go to what is it called? The GOPD. The medical doctor is going to assess them holistically, and then they will say, okay, you have a cardiac problem, go to the cardiologist. You have a musculoskeletal problem that is organic in nature, go to orthopedic surgeon. You have a movement impairment, that is movement related, go to a physiotherapist. By the time they come to us, we only assess them to confirm what is within our scope of practice, and then we plan for the treatment, we give the treatment. We can be able to do that. The patient has been assessed for the physician to be able to know if he has another underlying disease that is not within the scope of their practice so that they can refer. So they have done that. But now that we are first contact practitioners, we can see patients direct access. If we start with the chief complaint is going to create a bias in our mind. The word that the patient says, I have low back pain, I have neck pain, I have pain in my knee, it has already biased our mind that there is a musculoskeletal problem. And therefore, we are not really having that open mind to be able to ask a lot of questions about risk factors so that at the end of the day, we can use clinical reasoning to be able to say that, look, I suspect a GIT problem. I suspect a urological problem. I may not treat that, but let me know if the patient has it because he's coming to me first contact. If I only suspect musculoskeletal or neurological problem, I will now begin to treat the patient and I will leave them with an underlying disease. And the fact that they didn't go through a physician, it has been missed. And you leave the patient with that until symptoms begin to appear before treatment begins, and it will be more difficult to treat because it wasn't targeted before the symptoms began to appear. Through understanding yellow flags and red flags, you'll be able to target treatment or prevention at a very early stage. And this is one of the reasons why we can't continue to ask patients about their chief complaints early, the moment they come in. So for us, we need to educate ourselves. We need to continue to discuss these issues. And this is what we are going to deal with in systems review. These issues of when do you ask the patient about their chief complaint, when do you do system review or review of system, and all those things. Now, to the patient, if I'm in an environment where a patient is always asked about their chief complaint, I will now explain to them now. You are coming to me. I'm not sure if apart from what is within my scope of practice, you have another underlying disease that I need to refer you to another profession. And therefore, bear with me. Before I ask you the chief complaint that brought you to me as a professional, I'm going to ask you some questions that will help me to be able to know if there is any underlying disease so that before it gets to the point that symptoms will begin to appear and disturb you, let me refer you so that they can help you prevent it from coming, or that they can help you to treat the symptoms that have not really become of concern to you. Before they become of concern to you, let them quickly treat it so that the early treatment will get rid of it before it now becomes one that cannot be treated or one that will take much longer. So this is part of looking at patient preference. You are explaining to them, you are carrying them along, but what are you using to do that? Your clinical reasoning, your understanding of what it means not to do that or to do that. So these are the thoughts that should be coming to someone's mind. In all what we have done in those 22 items, we were looking at risk factors, risk factors, risk factors. And that is why you'll see 4 things in this section. Number 1, biodata, the age of the patient, the gender of the patient, and where they live, biodata. Past medical history, what sorts of diseases or injuries have they had in the past that will make them to be at risk of having other diseases now. The third thing is family social history. So family history is talking of genetics. Your father has had stroke, you may be at risk of having stroke. Then social history, those issues of smoking, alcohol intake, a sedentary lifestyle or active lifestyle. Number 4, which in this template, and I don't know why, came after the current condition, is medication. Because there are some drugs that you will take, such as, say, NSAIDs, that will predispose you to having GIT problems. And therefore, this also is a risk factor. And I usually count them as part of those things that I will do before I get to chief complaint. By the time I complete this section, I would have used my clinical reasoning. After the examination, now what is the evaluation that we dealt with in evidence-based practice class? This is a patient that is a female. She is 70 years old. She smokes. She takes alcohol. She's sedentary, has sedentary lifestyle. If from the test that they have done before, that they are coming to you with, you see that the lipid profile is abnormal. All these put together should make you to think or suspect that this patient has cardiovascular disease. So can you see that at this point, you are thinking of systems of the body? So is it one that is amenable to physical therapy? Or is it an organic pathology that the patient need to be referred? That is something else also that you need to start thinking about. And that is what now constitutes the clinical decision making. Should I keep the patient or should I refer the patient? I've examined, I've evaluated, I now want to make a decision, whether it's a physical diagnosis or whether I suspect an organic pathology that I'm going to refer the patient to another profession. So, of course, functional status, very, very important. This is a narrative reasoning. You're asking the patient about their functional status. Can you lie down? Can you sit from lying? Can you stand up from sitting from the bed? Can you walk without support? Because these are the things that will help determine at what level do you begin to rehabilitate the patient. Some of us will want to impress the patient's relative, and the patient cannot sit unsupported. We'll just stand them. We'll put back slap. I always give example with back slap. Someone has told me it has its own place in the practice. I said, give me an evidence. Where is it that they use it and say it has led? But he said there is. The person has not given me. I've not gotten one up till now. I'm not going to condemn it because I don't have the evidence. I can't rule out its importance in use. But I will not use back slap to stand a patient that has a neurological condition that I know the patient can recover if they learn through motor learning how to stand. The brain now learning how to instruct the knee to extend. I would rather do that, because if I put the back slap, one person hold the right hand, another person hold the right armpit, and the back slap is at the knee. Maybe there's even a third person coming from behind to hold the waist of the patient. You are increasing the independence. And what rehabilitation is all about is to make sure that you reduce the dependence of the patient. You make them more independent. And what do? If I know they can't sit from lying, I will do rolling exercises and other exercises. By the time the patient can sit, but they cannot sit on their own unless someone holds them, I will do trunk exercises in sitting. And then when they can be able to sit on their own, I'll put them in standing and I'll do balance exercises in standing. And it's only when they achieve that I will not begin to ambulate them. But you want to ambulate them when, especially in neurological cases. Now, the same thing might apply also in some instances to orthopedic cases, but all depends on the specialties. You want to impress the patient and you rush to get to another functional level, activity level, missing out those that are necessary prior to that. That may not be logical, and it is clinical reasoning and decision making based on understanding of anatomy, physiology, balance, and movement, whatever is put together would help you to be able to decide, is this the right time to stand the patient? Or is it not the right time to stand the patient? Let me go back, do rolling, do sitting exercises, do this before I now get to that level. This is part of clinical reasoning, but it comes from the part of clinical decision making, coming from the clinical reasoning, the thought about what it all means and why I should decide on where to start from, what level to start from. I've talked about medications, then other clinical tests, if they have already done them. If they have not done them, then at the examination level, you're going to send the patient to do all those things. Then this is something we are going to discuss when we get to Saturday, looking at systems review. As a first contact person, you are going to review every single system of the body. You are going to ask the patient about their GIT. When you eat, the pain that you have in your back, or in your back, for example, or in your shoulder, because shoulder is one place where so many organs of the body refer pain to. That pain in your shoulder, what happens to it when you eat? The patient says, oh no, anytime I eat, within 30 minutes after eating, the pain goes down. But an hour after eating, the pain comes back. That pain is not a shoulder pain. It's coming from the gastrointestinal tract of the patient. You ask the patient, this back pain that you have, are you sure? When you move, any changes in the pain? No. I will palpate, do digital compression test. Nothing changes. Say, look, when you urinate, what's the color? Is there any pain? What is the frequency of urination? And you'll get all positive answers. The color has changed, it's darker. I feel pain when I urinate, and I urinate now more often than I used to. All this put together, you are suspecting that there is a urological problem, and it's very possible it's the urological problem that is referring pain to the back. The biliary system, the hepatic system, all other systems of the body. As a physiotherapist, you are trained through systems review, which is a course in DPT, for you to be able to assess all the systems of the body, either to see whether it's the one referring pain to where you want to treat, instead of treating because it's not musculoskeletal, it's not movement impairment, it's an organic pathology, refer the patient, and you'll be able to know where to refer a patient. This also is a clinical decision-making matter. But what brought about the decision? It is the thought that comes to your mind that, look, this pain is in the shoulder. I've palpated. I have done all movements. This pain is not changing. No, what's happening? Let me ask about the patient's chest. It's very possible that we say, okay, how's your breathing? Oh, I have difficulty breathing. Or do you cough? Yes, I cough. When you cough, what happens? I bring out sputum. Oh, this shoulder pain could have been referred from the lungs. You are now asking the patient, how is your, do you get tired easily? You ask questions that will implicate the heart. It might be from the heart. It might be from even the kidneys, because when kidneys are inflamed, they begin to touch the diaphragm. And when the diaphragm is irritated, it refers pain to the shoulder. So shoulder can get even hepatic system, biliary system. They can refer pain, the liver can refer pain to the shoulder. And therefore, when your patient has shoulder pain, you need to do systems review. And when patient has back pain, it could be from the lower urinary tract, it could be from a number of other organs. This clinical reasoning, you are thinking based on the knowledge that you have. If that knowledge comes from books, this is what is called analytical cognitive process. If it comes from having seen patients and you have built a trend over time, then that is part of what is called a non-analytical cognitive process. So what we have here, I'm not going to go through, but it's all part of assessing all the systems: integumentary, neuromuscular, musculoskeletal, cardiovascular, and pulmonary system. These are things that we'll deal with when we look at systems review in the next modules. So then that's when, so at the history level, before you come to this, or possibly around this part, after asking the chief complaint, you are going to take the history. In the history is where you are going to narrow down from the systems that you suspected. So how do you suspect the system? From that preliminary stage, biodata, past medical history, family social history, drug history. I give you an example of how I suspected a cardiovascular disease. When you come to chief complaint, then maybe in the chief complaint, the patient will say, I have neck pain, and you now begin to think of a musculoskeletal problem. Your history is now going to focus on asking questions under the cardiovascular system and the neurological system. So that at the end of the day, after history, you will now be suspecting one or two components or categories of conditions under that system. It is that category of condition. For example, in neuro, that's what I know more of. I'll give example there. You can think of inflammatory, vascular, degenerative? And how do you do that? From the questions that you ask. Ask the patient, this condition, when did you start to feel it? 3 months ago. Over how long did it take for it to reach the maximum symptoms you have ever experienced? And the patient will say within minutes or hours. I've given an example during our evidence-based practice. So that is a question that shows you that it's an acute presentation. Acute presentation goes with a vascular problem like stroke. When you ask the patient, say 3 months ago, over what period did you get the maximum symptoms? You say over 2 months before I started to feel. That's more of a degenerative condition, because the degenerative condition continues to get worse and worse and worse, not over minutes or hours, but over months. That is a degenerative condition. So the same thing, when you ask about the pattern of progression, is it getting better? Yes, this is something that looks like vascular. Is it getting worse? Has it been getting worse? Yes, it's more degenerative. So onset of the disease, pattern of progression can now lead you to say that I've narrowed down to a vascular problem, or I've narrowed down to a degenerative problem. And you are going to see how that will feature in the physical diagnosis that we have. In our physical diagnosis, you don't narrow down to a condition that is medical to say that, oh, I've said it's vascular. You are not saying that it should be a stroke. No. You are a physiotherapist. Why should you make a diagnosis that is medical? You don't treat stroke. Why should you make a diagnosis that's stroke or lumbar disc polyps or cerebral palsy? All these are medical conditions, but knowing whether it's progressing or it is getting better is important to you, because you are going to rehabilitate this patient, and therefore you need to put it in a category that you will know, as I rehabilitate them, are they going to be getting better or are they going to be getting worse? But you don't need to narrow down to a medical condition, because you are not a medical doctor. That is what medical doctors do. They treat organic pathologies. They should make diagnoses there. So of course, you have now narrowed down to a category of condition. It is that category of the condition that you are now going to come and do your examinations. So all the examinations that you do to look at the signs of diseases within that category of condition. So let's say degenerative conditions. What are the signs of diseases in degenerative conditions under neuro? You now begin to assess them. The muscle power, the balance, and this. So you keep assessing those things. So that at the end of the day, you will now come to reach one physical diagnosis, or you would have suspected the presence of an organic pathology and you don't make the diagnosis, you only refer. Now, what sort of diagnosis can we make? These are what are called physical diagnosis. Please, can someone just let me know if everything is going well? Can you see the slides? Am I too fast? Is everything going well? Because I've not really interacted with you for almost an hour from the time that I've started. Please just give me feedback so that I'll be able to know if you are following, if you can see the slides well, you can hear me well, any network problems, everything is going on well. Okay, wonderful. It's going well. So, okay, that's great. I appreciate that. Okay,
it's going well.
Okay, that's great. Thank you. Thank you. So these are the examples of physical diagnosis that we can make at the end of our clerking process. So there's nothing like cerebral palsy. We don't make diagnosis cerebral palsy. That is a medical diagnosis. When you say lumbar disc prolapse, it's about the nucleus pulposus within the disc oozing out through the annulus fibrosus and coming out. This is an organic pathology. It's not a movement impairment, even though the cause might be movement impairment. And therefore, you now have terminologies that are movement impairment. I can't remember what date we are going to have human movement system. That is where I will deal with what is human movement system. And that is what is going to now determine where we come in and how our physical diagnosis should come out as. So what I have here are examples, but it is in human movement system, kinesiopathology, and pathokinesiology. That is where we are going to deal with how to make a physical diagnosis. So we are going to see things that even go down beyond what we have on this slide. Dr. Jibril, do you remember whether we have human movement system in the series? Okay, if you are not there, I will check later. So this is physical diagnosis. Under musculoskeletal, you are looking at things like impaired muscle performance, impaired joint mobility, motor function, muscle performance, and range of motion associated with connective tissue dysfunction. You can see that there is nothing that is medical diagnosis in this diagnosis that we have. Under cardiovascular, you are dealing with like B. It says impaired aerobic capacity, endurance associated with deconditioning, impaired ventilation, respiration or gas exchange, and aerobic capacity or endurance associated with airway clearance dysfunction. Under neuromuscular, you will see things like impaired motor function and sensory integration associated with non-progressive disorders of the central nervous system. Can you see these non-progressive disorders is the vascular one that I talked about? It didn't say stroke. From the look of it, this patient may have stroke. Possibly it might be traumatic brain injury, because what we are after is if it is non-progressive and he has impaired motor function, because that's what I'm going to treat, impaired motor function. I will treat sensory integrity problems, sensory problems. These are the things that I will treat. And therefore, my diagnosis should reflect what I treat. If I say the patient has stroke, stroke is about a vessel blocked. What intervention of physiotherapy am I going to use to unblock that? When there is a burst, what intervention am I going to use to block the burst so that the brain will stop oozing out and disturb the brain? But I treat movement impairment. I treat gas exchange. I treat impaired aerobic capacity. These are the things that I treat. Under integumentary, impaired integumentary integrity associated with partial thickness, skin involvement, and scar formation. These are some of the examples of the things that we treat, and therefore our diagnosis should reflect that. But how did you get to the diagnosis? It was through clinical reasoning, and then we made a decision. This is the decision, because the diagnosis is part of the decision that we make. The fact that we need to refer is part of the decision. Now, with our prognosis, prognosis comes from the same thing, what we did in the assessment. How do we now use those thoughts of what we have collected to be able to do a prognosis? Remember, when we did evidence-based practice, we talked about three things under prognosis. Number one, we need to have a recovery. Number two, what are the factors that will determine the recovery? Number three, how long does it take to have that recovery? Now, for example, the severity of the disease. That's number one, a factor. The age of the patient. The higher the age, possibly the longer it takes to achieve a particular recovery. The more the severity, the longer it takes to achieve a particular recovery. So I have a patient that has cognitive decline. He has stroke. He has cognitive decline. He has movement impairment, motor function problems, and sensory problems. I want to treat the patient. But this patient has cognitive problem. If I want to give them task-oriented training, I need to explain to them for them to understand so that they can be able to follow the instructions, because the brain will only reorganize itself if the patient does the tasks themselves. My passive movement is not going to change anything in the motor area of the brain. There will be no reorganization. I'm sorry I'm giving you most examples through neuro. I'll try to bring in other professions, but I'm in neuro and therefore I'm more comfortable giving examples there. So if the patient does not understand, it will take them longer to be able to have that reorganization. And therefore, from my assessment, I've asked the patient TPP, time, person, and place, in my history. When I come to examination, I use the mini mental state examination, and I realize that the patient has gotten a score that is less than 23. So maybe he has 18 or 17 or 16. And I know that means that he has a cognitive problem. And therefore, I'm not going to count that as something that will help me to know that it's going to take him longer than normal to be able to achieve a motor function through reorganization of the brain. There's a patient that's had low back pain, and I realized through some assessments that he needs stabilization exercise. Maybe you will say, I'm always giving examples with stabilization exercise. I gave you a story during last lecture of how I got to learn from an intern about stabilization exercise. It was very interesting to me. When I give examples in musculoskeletal, I try to give that example. So that exercise will require that the patient goes on all fours, knees and the hands, and then you ask the patient, raise one hand and then raise the opposite leg. Someone that has a cognitive problem will have difficulty doing that. Someone that is 70 to 80 years old, apart from the problem of the multifidus muscle in the back, they are going to have a problem with balance. They are going to have a problem with stretching of at their joints, and therefore it will take them longer to be able to do those exercises like a younger person will do, and therefore activation of the multifidus muscle that is going to help them have stability in the back will take longer. These are all prognosis. How do we get the prognosis? We get it through examination, because the cognitive that we talked about, it was through examination that we got it. The issue of their age is through examination that we got it. This is data. But then how do we interpret the data? We put it together. Age, cognition, severity of the condition, all this put together will affect the ability of this patient to be able to sit without support. And therefore, it's going to take them 3 months to achieve that. In a patient that does not have all this, it might take them only 2 or 3 weeks to be able to achieve that. This prognosis, it comes from knowledge, through experience, and then we make a decision. Analytical or non-analytical cognitive processes. Of course, narrative review is going to help you to set goals. This is a patient that is an officer in the office, he writes, and therefore my training should include dexterity exercises to the hand so that they can be able to write. This is a footballer. My training should include a lot of balance and coordination exercise for the lower limbs and the trunk so that they can be able to go back and play football. So my goals will depend on the examination that I did. It's still coming back to clinical reasoning through knowledge and also clinical decision making. What are the outcomes? That is when I now begin to think of what interventions to give. And any intervention that I'm going to give will depend on the narrative review. It will also depend on the symptoms and the signs that have itemized as being negative in my assessment. There is nothing like one package for all. The patient comes, they have stroke, you must give them bridging exercise, you must give them walking re-education, standing re-education. There is no even dosage. Just say, give him walking re-education. How long should you do that? At what speed? When do I increase the speed? How many days should I do it in a week? Nothing. Then education. We need to educate them. That's part of understanding the patient's preference so that we can know how to educate them to be able to accept our own perspectives and also do their home programs. And that's all part of it. Then discharge plan. Our prognosis should determine what our discharge plan should look like. So this is a template. It has taken me 1 hour to explain, but I don't regret doing that because when we go to the slides now, it's going to be much easier to understand the slides. We are going to be referring to this template, and we are also going to be thinking more clinically. What did we do to our patients so that we can be able to understand this from the clinical perspective, not an academic perspective. So at this point, I'm going to stop and ask if you have any comments or questions, or you want to share some experiences before we go to the next stage. Thank you.
Thank you, sir.
Okay, so anyone with a comment or question can raise their virtual hand so that we discuss before we proceed. Please don't be too, wonderful. Michael Ogule, yes, go ahead, unmute and speak.
Okay, hello, good evening, sir.
Yes, good evening.
Okay, thank you, sir. And my question is, how can we give an accurate prognosis if patients are not consistent with their home programs and also their sessions?
Okay, thank you. So I think
Thank you, sir.
that issue is also part of the factors that determine recovery. So adherence is a topic that usually comes under a course that is called uh, uh, psychological and social constraints in health and disease. When I was doing my master's in Southampton, it was one course that I enjoyed a lot because we talked about adherence and compliance. So this is something, Jibril Samani, if you are there, please, or you or Hafiz, take note. Let's have this. I know Professor Adam Rufai has done, I think during his master's or PhD, it was related to public health. He dealt a lot with the issues of adherence. So let's have a topic that we can have maybe in times like this evening time, just 2-3 hours. Let someone talk to us about the issues of adherence, how it affects recovery, and how we can be able to deal with that. How do we now understand why the patient is not adhering to treatment? How do we now use our psychological and social constraints, knowledge to be able to deal with that? Can you see that this is also a decision-making thing? But decision-making has to come with clinical reasoning. But clinical reasoning has to also come from knowledge. So if you don't have the knowledge, you can't think of something proper. If you can't think of something proper, you can't be able to make a decision based on the thinking that comes from an informed whatever. So these are issues. So that issue of adherence can be a factor on its own. You say that, okay, the prognosis of this patient will be better with adherence. It will be worse with non-adherence. Then you will now begin to think, how do I now understand the adherence? How do I know what factors affect the adherence? How do I improve it so that what I'm after is for the patient to now get better? If I improve the adherence, then the recovery is better. The time it takes to have the recovery also is better. So deal with adherence itself, and as a factor that affects prognosis of the patient, you'll see that the prognosis will improve. Thank you. Yes, Majida Musa.
Thank you so much, sir. Good evening. Good evening, everyone.
Yes, good evening.
Sir, I just wanted to bring out a suggestion.
Yes, okay.
This assessment that you presented to us now is like after outpatient form.
Yes.
I don't know if there is a way that we can get something like this so that it will be unified across every hospital on how we assess patients and how we carry out so that it will be unified. I don't know if that's possible. Last year during the regional workshop that took place at the Abuja venue, also suggested similar something like that to Dr. Anjorin. And because when he presented about assessment using the body quadrants, so we also suggested something like that. So I don't know if it's feasible.
It's feasible. It's very possible. I remember when I presented this last year, maybe early last year, there was a question like this, and I promised I was going to set a committee to review and kind of adopt for use in Nigeria. And then at the board, we can be able to approve it and send it to all departments for use. But I was not able to do that. So please, Majida, can you help me tomorrow around 9:30 to 10, or maybe after 12? I will have a meeting in between. Just send me a message, just as a reminder, so that I will now call someone in the office and ask them to coordinate how we can call people to serve as a committee to review, so that the moment they make a submission, we'll approve it And then after approving it, we'll send it to all departments. We'll send it to CMDs and say, this is something that has been approved at the board, and we are recommending that all physiotherapists should be using it in their clerking. But of course, we need to validate. We'll need to carry people along, because those that will implement need to understand it, need to accept it, so that when it gets to them, it's only the implementation. If we don't carry people along at the point of implementation, they will say that they don't accept it. Just like I've explained to you earlier, the resistance that we face in some places because of the issues of understanding what it's all about. So please just help remind me tomorrow so that we can begin the process. We'll take it through the process of development, adoption, and adaptation. Oh, sorry, to adapt, not to adopt. We'll adapt, and then we'll validate, and we'll carry stakeholders along, and then we'll send it to hospitals. But let the process just begin. So we'll do that tomorrow, God willing.
All right, sir. Thank you very much. I'll
Yes.
remind you.
Thank you. Yes, I can see Ayeno one Sunday. After that, I have a Utayo Ayodeji with a message online. Yes, Mr. Sunday, go ahead.
Oh, thank you, sir. I want to actually appreciate you for this presentation. And good evening, everyone. I just only have probably, will I call it a comment or a kind of suggestion. When you present, the presentation is so beautiful and I equally enjoy it. But when you make the diagnosis,
We can't hear you again.
when you make
I can't hear you.
diagnosis.
Sorry, can you come again?
I said you gave examples. For example, you are giving some neurological diagnosis like
Yes.
sensory and motor function impairments.
Yes.
So, if, for example, in the documentation, because most of the challenges that we encounter generally in physiotherapy, documentation is somehow some of the challenges some people are having. But
Yes.
some of us are trying to emphasize that documentation is key. And when you are documenting, say for example, you are documenting and you are making diagnosis, the diagnosis you are given in terms of physical diagnosis, to me, is a key. But then it takes some clue from the medical diagnosis. Let's say, for example, the cerebellar is malfunction or is affected, and in a way, the different domain of a stroke, where stroke can occur in the brain, they are of various forms. And when the medical doctors diagnose theirs based on the, let's say, the radiological investigation and some other investigation they must have carried out, and they come out with their diagnosis. I take clue from that diagnosis, but notwithstanding, I have my own physical diagnosis, which is going to give me inform my decision making and give my plan where I'll be able to outline my plan in order to achieve the desired goals for the patient. Now, if we trying to ignore the medical diagnosis, for example, if I'm not available at the time someone is going to take over from me to attend to that patient, if it's just only the diagnosis of mine, which is the typical one, it could interfere with, there could be some confusion somehow. In a way, if the other person doesn't have ground knowledge of this, could be a kind of thing key from the patient. To see that when we are trying to bring out our physical diagnosis, the medical diagnosis should equally be. So that is why I have suggestions of two. I said the medical diagnosis and then the physical diagnosis. So that if ever coming to take his skill from me, he knows that this is the medical diagnosis of this patient. But I'm very able to assess this patient and I inform my decision to stay this patient equally, having the physical diagnosis, which is my domain of managing these patients, that will form my plan or forming of the plan that I'm having for this patient in order to give the best treatment procedure and get good results. But that does not mean that we should just see the medical diagnosis and trying to literally, project the physical diagnosis in such a way that we now cloud the medical diagnosis and it does not seem to have light anymore. And that's because in different institutions, we should have it at the back of our mind. We are not the physiotherapy managing. It's not single-handedly handling that patient. It's in a team approach. So that teamwork, it should equally be reflecting where every team member knows that this patient have this also medical diagnosis. And if the surgery diagnosis which is the physical diagnosis, are equally being incorporated in the process where the documentation is equally reflecting towards managing this patient properly, and everybody is carried along. I think I want to believe that it may not be an absence.
Wonderful. Thank you so much. Well, I can see your speakers still showing. I don't know whether it's network. Okay, go ahead.
These are faced with the medical. So the suggestion is that the medical diagnosis should not get lost. It should equally be part, having two diagnoses, medical and the physical one. Thank you, sir.
Okay, but let me ask you, who makes the medical diagnosis? Are you saying the physiotherapist should make both diagnoses? No. Or are you saying in the record, the medical diagnosis should be there?
No, this is it. The referral
will have the medical. Okay, I get it.
If we take a referral for medical doctor, which most of the institutions, especially government-owned institutions, the medical doctor makes their diagnosis. They make their diagnosis and information and the informed decision, trying to give them the knowledge that physiotherapy can play a role. By extension, they refer the patient to us. Okay. So in referring this patient to physiotherapists, it is their decision making, their diagnosis which they have made. Has made, okay, this patient has come down with some physical impairments that physiotherapy has to come in. When physiotherapy is not taking that referral, the first thing he will probably see is the medical diagnosis. We're not seeing the doctor anymore. It is the referral documentation that gives us that doctors are referred and saying this patient has, for example, we say it has cerebral stroke. And we have different types of the brain structure that could be affected and come out with stroke. It could be MCI, middle cerebral. It could be this and that. So if it now comes without diagnosis, we want to say, okay, yes, cerebral. The cerebral which you have has to do with some gait problem and the imbalance and what have you. Then I begin to now explore that and come out with its own physical diagnosis. So the primary one, which is the doctor key foundation, I think we still have to equally carry that along. So that when I'm not there tomorrow, subsequent physiotherapy coming to take over, you equally know. Because if I incidentally get lost of that medical diagnosis, other physiotherapy may get equally manage the patient wrongly, and the patient may not get best management plan. That is my take.
Okay. Thank you very much. I appreciate this contribution, and that's why I always like for us to have that opportunity for people to make input, because all of us can learn from each other. So number one, the things that you have mentioned in the slides that we are going to look at, there are three things usually that help with clinical reasoning. Number one, they say basic science or basic mechanism of disease. So the basic sciences. So what you have been talking about, the issue of cerebral stroke, middle cerebral artery, anterior cerebral artery, these are all information that's going to help us to be able to even understand what the problem of the patient is. The second thing is what they call illness scripts and schemas. And this is information that comes from understanding of risk factors, symptoms, and signs of diseases. Then number three is what they call exemplars. So this is what comes through experience. The basic mechanism of disease, the illness scripts and schemas are the ones that come from books. You read them, you now use them to be able to make clinical reasoning and decision making on the patient. So all this need to be recorded, because if you don't have them recorded, what you based your clinical reasoning on to get to the decision will not be there. If another person comes and they want to query your decision, they wouldn't have anything that you would have used to justify why you made that decision, and then they wouldn't have anything to counter you with what they have, because there is nothing presented there. So very, very important, the recording. Secondly, it's part of professionalism to record. And that is why in the board now says you can't just go and do workshop on practice. You learn how to apply this, no. So you must do leadership and management. You must have training in professionalism. And part of professionalism is this. If you don't record, just like you have explained, someone coming to talk over from you will not be able to know what you have done and how to proceed and how to make decisions. So very important. And if someone does not record in their place of work, it's part of what we have, what do you call them, surveillance volunteers in the board. And part of what they will do, we said, if someone does not go to work, report them. If someone goes to work, they don't record, report them. If someone does not teach, so now quackery is going beyond, or issue of surveillance and inspection by regulatory bodies is going beyond someone that is not a physiotherapist practicing. It's going beyond someone that doesn't have a license practicing. These issues of professionalism are part of the things that regulatory bodies can discipline someone who collect your license. So you can't practice because you are unprofessional. You are not recording the things that you do, so that if you fall sick or you take leave, someone that will continue to see the patient has to start from the beginning. You have wasted patient time. You have wasted resources of patient. You have given trouble to that person. Everything will get muddled up. This is unprofessional, and you must be disciplined. We'll take your license. So I agree with you very, very strongly. These things are really very important things, and they should be considered. Eichayo Ayodeji.
Thank you, sir.
Yes, sorry, before you speak, Ichayo, I think the last thing that you mentioned about the issue of the medical diagnosis, I also agree with you, but what I'm going to just add, apart from the importance of also understanding and knowing what the medical diagnosis is the fact that there could be missed or misdiagnosis by the physician. There are researches that have shown that there are many medical doctors, even at specialist level, that will misdiagnose or miss the diagnosis. And therefore, don't depend solely on the diagnosis that comes. That is why we do systems review. Because in your systems review, you can realize that there are suspicions or red flags for another system of the body apart from the one that the medical doctor diagnosed. And therefore, you can now write back to the medical doctor and say that you can't tell them that your diagnosis is wrong, and you can't tell them that this is what I think the diagnosis is, but you just list those symptoms and signs that you have seen and say that there are red flags for particular system. And therefore, I'm just referring to you for your further expertise or whatever, so that they can now deal with it. So that if there is an error in what they did, your systems review will suspect that there was an error and you refer back, but you don't go ahead and make the diagnosis. That's just what I wanted to clarify from you, and you clarified it well, that we will not make the medical diagnosis, but we need to know it because it will help us to be able to work within a multidisciplinary environment. And at the same time, it helps us to be able to know if there is an error for us to now send back a referral for them to look into what we saw as a red flag in another system of the body apart from the one that the medical doctor made their own diagnosis. Yes, thank you. So, Eitayo, please, can you unmute Mr. Ayodeji?
Yeah, good evening, Prof.
Yes, good
Good evening, everybody. Yeah, this has become very interesting to me this time. Yeah, I have a little question that have been bothering me all the while.
Yes.
You made mention of using of backslap.
Yes.
Yeah, in the usage of backslap, is it contraindicated in the treatment of patients that are having upper extension of the knee of the affected side? Because I think actually work on that, and I think it really works. Because some of them, probably most importantly, what I observed was if it is affectation of the left side, I guess that most of them do have upper extension of the knee compared to I have a kind of a trend that I used to understand that when I treat this kind of a patient with that is having CBA or CBB or whatever, I discovered that most of them that are having the left affected side do have upper extension of the knee compared to those that are having the right one. My observation though. So that I'm not asking that, is it contraindicated to make use of backslap for patients? Because thinking that probably later in life they might be having a kind of upper extension just for that to sustain them for a while when they were able to ambulate well, when we are putting them in a standing position when treating them. So what do you actually suggest? Is it contraindicated or indicated for a while, and which period is it being indicated for the patient?
Okay, wonderful. Thank you. That's a very, very good thought. Remember when I was speaking, I said two things just to be cautious, because I can't claim to know everything. Knowledge is wide. Unless I have evidence to say someone is wrong, I can't say someone is wrong unless I have an evidence. But let me explain to you what I mean by the statements I made about backslap. Now, there are two situations. There is the issue of recovery. There is the issue of compensation. So your prognosis is going to indicate, can this patient recover? This patient may not recover, and therefore he needs compensation. I will give you an example. In a patient that has complete severance of the spinal cord, so they have spinal cord injury, it's a complete one, are we expecting that patient to recover the use of their lower limbs? It's a no. They can't recover. And therefore, is it all right to use backslap and stand them with a walker, and then they will use their trunk to propel the limb to move forward? Yes, very okay, very all right. Should I remove backslap and begin to train the brain to send impulses to the lower limb to move? No, I'm not going to do that, because I know my prognosis has already indicated that this patient, let me be sure my speaker, okay, it's on. Yes, so that this patient cannot recover. Why should I put this patient through all the hardships to get recovery? I'm not going to go through that. My prognosis has already clearly indicated there is an MRI or CT or whatever it is that has shown this is a complete severance. I am not expecting recovery. I will take the patient through compensation. Backslap is one of the things that I will use for the patient. Any other person I know can use that. There could be another technology, let it be used. There's this, what do they call it? Exoskeleton. They use it and it works well, but it's very expensive. This is a compensation. But this is a patient that has stroke. And before the stroke, the patient could have standing normally. They don't have any hyperextension. And after the stroke, we realize that the severity is not that much in the brain, meaning we are anticipating that another part of the brain can take over the function of that part of the brain. They may have hyperextension. Whatever they are going to have, what that is saying is the brain has lost the ability to control the function of the knee. If I use backslap, at that early stage that I'm expecting recovery to occur, reorganization in the brain to occur, what is going to happen is that the brain will not learn. The only thing that will happen in the brain is for it to learn how to walk with a backslap or how to stand with a backslap. But if you want to help the brain, because neuroplasticity or plasticity in general is about characteristics of an object to yield to an influence. But so it's weak enough to yield, but it is strong enough not to yield all at once. What that means is that It needs many repetitions. And there is no way you doing things for the patient will allow the brain to learn, because the effort the patient makes is what sends impulses to the brain. If it doesn't connect, it now produces what is called a dendritic aberration, and then it goes to what is called a redundant cell, and then it connects a synapse in the process called synaptogenesis. And it is only when that happens that another redundant cell takes over the function of a cell already existing, that now impulses will be sent down to control the knee function. And therefore, I will not use back slap in a patient that I am sure can recover. I will rather use motor learning to educate and train the patient to be able to have his brain control the knee. And then at the point that the brain controls the knee, he will continue to now have that ability to do that activity. But let's assume a patient has congenital problem, hyperextension. It's not about the brain injured. No matter what you do, the brain is not going to learn to maintain that position. Let's assume someone has an accident and they have laxity in their ligaments or tendons, and it has not been repaired, and the patient does not have the money to go for surgery. Should I now say that I want to train the brain to learn how to control the knee? No matter what the brain does to instruct the knee to remain in a neutral position, it will not, because there is a musculoskeletal problem there in the knee that is making the knee to always go into hyperextension. Now, can I use an assistive device to help the patient to compensate until they are able to do surgery? Yes, definitely I should do that. So whatever it is that we are talking about, it comes with a condition. Then secondly, is there an evidence? If you use it, it yields what we are looking for. If we go back to our evidence-based practice lecture, you will see that that's how a clinical question comes. You will now have back slap and the patient characteristics and the recovery you are looking for. Is it ability to stand? Is it ability to balance? Is it you now take those keywords, you search, you get an article. If the article says it is an RCT, because we say that's the minimum that shows high quality research, what do? You read it, you go to the conclusion. If your objective says that is what they intended to do, you go to your conclusion, you see that it says, yes, it's effective in treating that patient, just take it and use it. And you can challenge anyone. You can tell me, see, Rufa, you are saying we can't use this. I have an article, it's an RCT, published in so journal that is reputable. It says the use of back slab in so condition is effective. What can I do? Just keep quiet. But without that evidence, we can continue to go back and forth using what is it called? A theoretical framework. But there is no evidence. So these are the two issues I think that are important to take note of with these issues that you have raised. Thank you. Then Dr. Anozie.
I don't know if
Yes, go ahead if you want to speak. Go ahead.
Do I have the floor, please?
Yes, I thought Mr. Sunday wanted to say something. Mr. Sunday, do you still want to say something?
yes, sir.
Yes, so be very quickly,
Yes, sir,
please, so that we
please.
can have Dr. Anozie to speak.
Yes, the question that just asked that you are just explained. That
Yes.
The use of personal, for me, most time is not that by research. When you observe that, it depends on how, because this issue of the rule of nine, for example, is true. If we use this issue of the rule of nine to adopt in managing a stroke patient, for example, as he has explained, he has asked the question, you will discover that depending on which the physiotherapy managing that patient is going to take this patient, you have assessed this patient and you have come out with your diagnosis, and you want to see that you want to take the patient on. We know quite well the upper extension of the knee, which might likely be created as the time the stroke occur. But the taking of the patient to standing, most time, if you start taking the patient to stand, if you do not take, you have explained, if you don't take the neurospasticity into consideration and see the level of prognosis that the patient is going to assume, because we must be able to forecast that this patient, when you're taking him or her up, the affected limb may definitely go into upper extension. Then what do? Applying back slab might not actually prevent that. But then if you are starting the standing, you must be able to do what is called prophylactic, preventing that, upper extension of the leg. In some instances, they create a wedge to reduce the extent of that upper extension of the leg, because the ligamental lag, we definitely must have set, we want to set in, but the approach is what will prevent that, because the force taken up to standing that limb, bearing weight, can equally exaggerate the ligamental laxity, whereby it will not set it. But preventing it, which you must have envisaged, that could actually happen when you're applying back, then you should be able to create equally a kind of prophylactics preventing that from occurring. Because the process of neurospasticity, the moment it starts occurring in the patient recovery states, then whatever position or alignment you are going to put the patient on in order to recruit, neurotransmissions and all that, to enhance strength and all to the limb, any achievement you are achieving from the first start to the end where the patient begins to ambulate, and what is your target? That is what the brain will recognize, and that is how the patient is going to be. If you do not prevent creating a wedge, putting the backslap, in order to ensure that the upper extension is prevented, and you're able to get a good, reasonable result for this patient, where that's, deformity, so to say, it does not really occur. That is my take.
Okay, thank you very much. I think there are interventions that help in the issues of hyperextension, especially the ones that come after the stroke, not before the stroke. As I've said, if you have something before the stroke, possibly it's something that comes into the stroke that you have to consider. You can't ask the brain to learn that, because even before the stroke there was a deformity that makes people to have that. If you look at Bobat, and I think Bobat is one of the interventions that we are going to look at in this series. I know Jibril has added it there, Dr. Jibril Samani. So in Bobat, if you look at Bobat, one of the things they do, for example, you see the techniques. The patient is standing, a therapist is sitting, and they have their hands, one at the back, one placed at the knee. So just to give feedback, let's say the patient is standing and touch the knee and say, your knee is going forward. Can you move it back? That realization that they are moving it back is now beginning to send impulses to the brain, and the brain is now beginning to learn how to maintain it in that position. If you go and you go on databases, PubMed, you go on a number of databases, you use Bobat and knee extension and the condition, say stroke, then you are going to see a number of RCTs or even systematic reviews that have looked at Bobat as an intervention to treat such kind of problem. That's evidence-based. Another one that you can look at is functional electrical stimulation. You are going to see that a lot with the hand, but there are few also that are for the lower limb, the knee or the ankle. There are. So you can look at them. So if this issue of the use of backslap is indicated or not indicated, if you use it using common sense, of course, that is going to not evidence-based practice. It's not evidence-based, but it could be the best available evidence, maybe because we can call it expert opinion. It will be the best that you have at that point for use of backslap, not others, because if the others are there, that will not be best available evidence. But if you are saying the only thing that I don't have the expertise in Bobat, I don't have the stimulator that will do functional electrical stimulation. The only thing that I have is a backslap in my clinic, and that's the only thing that I can use, and there is no RCT, then using it is still okay, but it is not evidence-based, it's best available evidence. So, but if we search and we see a research, an RCT, that shows that it has been used in a patient, and the long-term impact still is that it did not lead the brain into relaxing itself and not learning how to do it permanently, meaning at a later time, after a year or two of using it, the patient still later regained the ability to control the knee, then we can say that, well, that's a good one. There is an evidence, and the impact goes beyond the 6 weeks in that paper, and therefore is acceptable, it can be used. So I think this is why we did evidence-based practice, because evidence-based practice has come, it has gone away with expert opinion. Expert opinion is at the lowest level. But remember, I'm not undermining expert opinion, because I told you that any evidence that you have at the level of RCT and above, it came initially as an innovation through expert opinion. But if you have an evidence and you have another concept that is an expert opinion, then the evidence, RCT and above, supersedes that, even though it's the foundation that will now give you the evidence. But in as much as there's an evidence and there is something that is expert opinion, pick the evidence, leave the expert opinion until the expert opinion goes through research and it comes in as a high quality evidence. That is when you can now, it can compete with other things that are available for the patient. But this is a very interesting one, and I'm very happy that there are very interesting ideas that are coming. That is the purpose of having this, so that we can go back and continue to think and reason and make decisions that will be the best decisions that we can give to our patients. Thank you so much, Mr. Sunday. Dr. Anozie.
Yeah, thank you very much, Prof. Good evening, everyone. I really have learned a lot from, the presentation you've made and all that. And I was very happy when you mentioned that the transitional DPT is going to go along with the undergraduate DPT program. And the reason why I'm very happy is because one of the things that I've seen that a lot of physiotherapists who are practicing, we have the knowledge, but you find out that a lot of people are not documenting properly. So the issue of that documentation has been a big problem. And whatever you do that you don't document is more like you have not done it. So I love that format, and like the person who has said previously, and the person mentioned that it is good if we can adopt, a uniform, assessment format and maybe documentation format. We all know that we use the SOAP approach or the SOTAP as anyone uses, but it is not as detailed as this ones, that we have seen. If it's an international stuff, we have to really adopt something that will be uniform for everyone to use, so that if I know that this person is practicing and is using that same practice here and it's uniform, it's very important. And also the clinical reasoning area is very important, because most times it is the physiotherapist that may be able to find out that there is a problem that this patient has as a medical problem, and will point it to the physician. And I want to believe that the transitional GPT program will also give more insight into clinical reasoning, documentation, maybe pathological processes, because if you don't have the scientific knowledge, if you don't have rich knowledge of a lot of conditions, their signs and symptoms and clinical manifestations, you may not be able to find out things. And it's going to broaden the scope of physiotherapy, so that we'll not just be looking at the problem like in the musculoskeletal area or neuro. Then we'll also be looking at it systematically and able to identify problems in that way. So I'm asking, between 2025 and 2030, is it feasible for physiotherapists or physiotherapists in Nigeria to be able to, who have not had their DPT, should be able to have transited towards DPT program? How is it going to be possible to achieve that while people are, let's say, working in the hospitals and everything? I'm thinking about the clinical area, because I know it's not going to be only academic. There will be a clinical part to what you have learned. You have to put it in practice and be examined on those areas. So how feasible is this goal, is it achievable within 2030 and all that? So I've just been thinking about that. Then the first question is about how do we adopt the uniform practice, the assessment format. If we are using outcome measures, we are going to be using the uniform outcome measures for different things and all that. So I just want you to throw more light on what the plan is. Thank you.
Okay, thank you very much. Number one, the issue of the template, I think I've asked Majda to remind me tomorrow. What we are going to do is to invite stakeholders from different perspectives. So we'll look at the specialties, we'll look at the clinic and the academia, we'll look at, all the categories of stakeholders that we think need to make an input. So we'll have them as a committee. When they complete the process, then we are going to send it out to almost everyone and say, have a look, and then send us feedback. So when we get the feedback, we'll then finalize, and then we'll now call for a validation meeting. And immediately after the validation meeting, we now send it out, as I've said, to all CMDs, all departments, all private clinics, and then we'll put it on our website. And direct people to go there and download. So that's for that. The issue of the DPT, I know you have a lot of passion on it. I think you are the one that sent me a message earlier today with a two newspapers information about DPT and FAMD. I think you might be the one. So the issue of 5 years, maximum transitional DPT will take you is 2 years, maximum. And that is why we went to the NUC. If we finally agree with them that all universities can start, and across, we have about 50 universities now that are offering physiotherapy across the country. If all of them start, and it is a separate program, not merged with the entry-level program, and you can start now, you don't have to wait until they get to 500 level. I think we can be able to take as many as possible. Now, if for any reason, before the start, and we look at challenges that are realistic, it's not just people making use of excuses not to do it. Then by the time we get to 2030, if there are genuine reasons that from our assessment we know it's not feasible, we can always go back to the governing board. Even if there is no governing board, we'll go to the minister who takes responsibility of the mandates of the governing board when there is no governing board, and we'll ask for an extension. But as I've said, this cannot work unless we know there is a genuine reason that it is not feasible for us to continue with the 2030 deadline. But for now, I'm very optimistic. It's possible. All we need to do is to continue to push, do advocacy for the universities to quickly start, push for people to go and do these courses. What is in the curriculum BMAS initially is that you have to go and be there full-time physically. And part of what we told NUC is that it might not be possible. People are working and they are going to go and sit down fully. And therefore, it's going to be somewhat of an adjusted program. If they approve that, then we are going to work with that. It will allow you to do your work and still be able to do the program. But let's get to the real, then we'll cross it. For now, I'm optimistic. All we are going to do now is to continue to push and do advocacy for these things to happen so that we can beat the deadline of the 2030. Thank you very much. Sani Tijani.
Okay, thank you very much, sir. Good evening, sir. Good evening, everyone. My own is regarding how we document our own diagnosis. Is there a way we can standardize how we document our diagnosis? Because sometimes as an intern, I used to come across documentations in which you see people writing impression, which to me, I think, sir, is implying lack of, say, confidence in what we have established from your history and other assessments. So, sir, is there a way we can standardize it to make it standard, a way we can document it? Thank you, sir.
Thank you very much. There is, just like we are going to set a committee to now look at the template for the data collection. We are going to set a committee also to look at what is available in the US and then pick other countries that also have gotten a template or a template for the physical diagnosis. So that we'll look at it. Let's see if we can adopt it or if we need to adjust and then adapt. And just like we are going to send to all CMDs and all everyone the template for data collection or the clerking, we are also going to send this. It's there. What I showed you in that document is just few that were picked. In fact, I have a document that's almost 30 to 50 pages that has information about this issue of diagnosis. And as I've said, in human movement system, if you get the chance, look at the schedule that we have released. That human movement system, what we are going to dwell on is just about how to make a physical diagnosis. So what are the factors that determine what your physical diagnosis should look like? We'll discuss the definition of physiotherapy from the perspective of the human movement system. We'll then now look at the concepts of pathokinesiology and kinesiopathology. We'll then look at what the human movement system is from the perspective of what systems of the body can be affected through movement, and then how you can use movement to treat them. And then we'll now discuss so how you come up with the diagnosis. So just find out when we are going to have that human movement system. You will get more of the concepts, but the actual template that will generalize how diagnosis. We're going to release that to all hospitals within this year, God willing. Thank you. I think I saw a hand. I keep, is it I keep? You put down the hand, you don't want to speak. Dr. Anozie. Yes, okay, yes, I keep, go ahead.
Good evening, sir.
Yes, good evening.
Thank you for the presentation. With regarding to what Mr. Santejani just spoke with regard to diagnosis, in a lot of documentation, because I'm in front of checking documentations, you will see a physiotherapist after assessing, making some examinations and other things relevant, they tend to write impression rather than diagnosis. Some will write diagnosis, some will write impression. So I don't know why, but I asked some people, they said they are not certain with their assessment. They couldn't reach a definitive answer to the assessment. So they rather make it an impression, what they feel like the thing is. So how does it look actually? What should someone do if they are not having certainty about their assessment or investigations? Thank you.
Okay, thank you. I think what they told you is that's the implication. That's what it means when you say impression. But it cannot be something that is sustained for a very long time. It is just something that is an interim thing. So if, for example, remember the way I explained the template, you start with your biodata, past medical history, family social history, drug history. What you are expected is to now narrow down to a system. When you go to the history level, you are now asking questions that Yes, sorry. A call kept coming in and disconnecting the network, so I just had to tell them to be patient. Yes, so if you narrow down to a category of system in the history, by the time you get to examination, you are now moving from the category, trying to find one diagnosis. But if in the process, there is an information that you need to collect that is not available at that point in time. Let's say, for example, to get to a particular diagnosis, you need a radiological investigation, or you need a laboratory investigation, or maybe it is an examination, physical examination, that the tool or the outcome measure to be used is not available at that time. So at that point, maybe you are now thinking of 2 or 3 conditions that you need that last part of the examination to now rule out 2 and rule in 1. At that point, you can now have impression. My impression is this. You can't give a plan of treatment that will achieve your goal. You can only possibly begin treating the impairment and some of the symptoms that the patient has before you reach the diagnosis. But the moment you reach a diagnosis, it can't be impression anymore. And you can't tell me that you can't get those examinations to be done within the next few weeks or months, that for 2 years, you will continue to treat the patient based on impression. That is not a professional thing to do. Unless if definitely there is no way the patient can be able to afford those examinations that will require that you narrow down to one particular condition, then impression can then be go on. It's a circumstance. Some people can't even go to hospital and get the care that they need. But in as much as you can complete the process, there is nothing like impression. Let me tell you what's happening. Let's be sincere to ourselves. The training that we have had is not a first contact thing. That's number one. Number two, the training does not have a lot of emphasis on evaluation. And this evaluation is one of the weakest points that we have in our practice. We collect data. I see files, anectinic acinos febrile for every patient. Sometimes we don't even look at the eye of the patient to see the color. We don't touch the patient to see whether the temperature or use a gadget intervention. But you see, as nictinic acinos febrile, oriented in TPP, gross muscle power 4/5. There is nothing like gross muscle power 4/. But we see a lot of that, especially in the past, 10 years and back. Now things are changing. People are doing the right thing. They are recording. They are using evaluation. They are doing all the necessary assessments. And they are getting to that. People are changing. I can't say it's like this for like it used to be. But we still are a long way from the point that we want to get to. But the good thing is that we have taken the step and we'll continue to move until we get there. We'll continue to have relevant trainings. People will continue to do masters and PhDs, understand the academic part. We have now clinical programs that are coming up, that through them, we are going to refashion them so that it will not also be an academic thing, but it will be a clinical thing. And being a clinical thing is going to accommodate all the relevant clinical areas that we need to have. Looking at the 6 components of patient management. How do we examine? What are the outcome measures that we should use? When we finish with assessing the patient, how do we evaluate what we have assessed? How do we make a diagnosis? How do we get the prognosis? What interventions should we give based on the earlier stages of the component of patient management? How then do you follow up the patient to see that they have been integrated back into their communities? I believe we now understand what we want to do. We may not be perfect in doing them. We may not be experts in doing them, but the fact that we have started the journey, I have a lot of conviction that in the next few years, the practice of physiotherapy is going to be different from what we used to have and what we have at the moment. Thank you so much. I think these are very wonderful discussions. I appreciate all your input, all your perspectives, and we'll make use of them to also build on what we have as a thinking in how we should progress and how we should advance. So thank you so much. I can see that there are no hands and it's almost 10. So the slides that I have, I've not even touched them at all. But whatever we have discussed is even more realistic than what we are going to see in slides. So what I'm going to do is just to take 30 minutes to brush through the slides. I will then send the slides to you. If having studied the slides, you feel there are some areas that we need to touch on, you can suggest on the platform any other time that we can come up, and I will give 1 or 2 hours free. No one needs to pay, so that we can discuss those things, we brush through them, and we get more information. But most importantly, we can share our clinical experiences as it relates to the issue of clinical reasoning and clinical decision making. So I'm going to share the slides. So wherever we have already discussed issues clinically, I'm going to just brush through. I'm not going to dwell on it. But since I have the slides, I think it's important to just go through them. So clinical reasoning, some of the thinking, because when you say reasoning, you are talking about thinking, it's thought. Some of the thinking and decision-making processes associated with clinical practice. So whenever a patient comes in, you start thinking by just observing the patient. The patient is trying to sit down and they hold their back and they sit, takes them few seconds to sit. The thing that will begin to come to your mind is that this patient may have a low back pain. A patient comes in and they are holding their hand up around their chest and their leg is being circumducted while they are walking. The first thing that comes to your mind, this patient may have a stroke. So this is clinical reasoning. These are thoughts that come from observations. So critical skill central to the practice of professional autonomy. Now, this is what we are talking about. For a long time, we were working as technicians. And that's why I keep telling people, I say, if you cannot make a diagnosis, you keep saying impression all the time in your practice, you are an impressionist. You are not a professional, you don't have professional autonomy. If you can't do evaluation, you can't practice professional autonomy. And therefore, clinical reasoning is the key to professional autonomy. You want to be autonomous? You need to have clinical reasoning ingrained in your practice. At any time people ask you, you can be able to explain from facts and evidence why you make this decision and why you make that decision. Enables practitioners take best judgment in a specific context. So as I've said, I'm going to jump slides. You can read them. Yes, let's just quickly look at the history. Clinical reasoning in the early 1970s. And that time, about understanding clinical problem solving. It was in Michigan State University and McMaster University, some researchers. What they did was to recruit experienced clinicians. So these are clinicians that have been practicing, say, for 10 or 20 years. And then students. So they had two groups. They observed the clinicians, experienced clinicians, and they observed the students. And the methodology was that they told the participants, we'll give you a patient to treat. We'll videotape you. But we also want you to think aloud. So the thought that came to your mind, what I was telling you earlier, the patient comes trying to sit down, hold the back, and sit down for some seconds with a wince in their face. Then I would now be saying, what I'm thinking right now is that the way this patient is trying to sit, I think he has a back pain. So whatever you are thinking, we want you to say it aloud. Since it's about critical reasoning, it's about thinking, we want you, that thinking that's in your mind, say it out. Let's know how clinicians think. So what they came up with at that time was what was called hypothetical deductive method. So from that thought, they now begin to make a hypothesis. And this is the hypothesis. The way you sit down shows that you have a back pain. Then I will now go through the assessment and then I will deduce. So meaning I'm confirming at a later time that hypothesis that I've set. So clinically, the evaluation we do, it helps us to have a hypothesis. The examination that we do helps us to confirm through the diagnosis what we have suspected to be the problem in the patient. That's what clinical reasoning is all about. So general processes, what they found out was that all subjects did the same thing. Experts were better at hypothesis, but they were not quicker because there was no organized process of doing it in the 1970s. They made a better hypothesis, so they were more prone to say what the condition was through the hypothesis than the student. So there was focus on expert knowledge than expert process. There was no expert process. It was just expert knowledge. They had more knowledge, they had more experience, but they were not doing things faster than the students were doing. Then in the 1980s, they came up now with the age of memory. So memory, performance, and expertise. The more you do this, the more you now see a trend. This patient came, I did A, B, C to them. I realized they had this diagnosis. If this patient comes and I do the first examination, the second examination, and it's similar to that one, I will continue to follow them up. If I see what I saw in that last patient, I will, at the end of the day, confirm that he has what that patient had. You are now beginning to come up with a process that will help you to make things faster, the decisions to be faster. So expertise related more to specific knowledge than general skills, but they are beginning now to bring skills by looking at the trends. Expert has access to extensive knowledge, which remains encapsulated until needed. In the 90s, that was when they now began to have age of mental representation. And three things came out. That if you want to make decisions faster through a process, there are three steps of mental representation, much more of looking at the trend. And this is where I was trying to explain when I think Mr. Sunday was giving those contributions. And I said, one, basic mechanism of disease. You need that knowledge. An example, you gave an example, I will give another one. An example is a patient comes with weakness in the lower limb and pain. From the initial presentation, the thought of the clinician might be that it is a musculoskeletal problem, either in the lower limb itself or in the lower back, referring pain to the lower limb, and also possibly in the lower back, there may be some compression that is leading into weakness in the limb. But another person that is in neuro will now look at that patient and say, look, when you have middle cerebral artery affectation, usually the patient will have upper limb affected more than the lower limb. But when you have anterior cerebral artery affectation in the brain, you have the lower limb more affected than the upper limb. And therefore, it's possible that it is even problem of anterior cerebral artery in the brain that brings about this, not a musculoskeletal problem. That is so. This basic mechanism of disease, understanding the basic mechanism of disease and relating it to clinical situation of a patient will help you to be able to reach a decision faster. But that alone will not give you that decision. But it is a thought that gives a hypothesis. And it is through illness scripts and schemas that you are going to now go through deductions to be able to confirm if that hypothesis that you have through the basic mechanism of disease is true. Because if I now come and do my reflex and I see that there is hyperreflexia, and I do test spasticity, I test for Babinski, I test for sensation, I test for a number of things, and I see that all those things are bringing in negative. Yes, there's a problem. Oh, no. These are signs that there is central nervous system problem, and therefore it's not a musculoskeletal thing. It is. But if all those things are going that no hyperreflexia, no this, no that, but at the end of the day, I do test in the back and I see that there is a problem in the back, then I will now say, okay, it's not the neurological, it is now. So basic mechanism of disease, very important. We need to go back to school. We need to read about muscles, our anatomy. We need to read about our physiology. How does the brain works in sending impulses? We need to joints. We need to study them. I always give example about this back, the multifidus muscle. We study them. How do we know that they have a problem? What is it that brings the problem? So that when we see the patient, we'll be able to suspect that it is not just the back, the bones. Possibly it's just small muscles that are not active, and therefore they are not protecting the back. And therefore the patient keeps coming back with low back pain. Let's just target the multifidus muscle through stabilization exercise. We'll be done with it, and the patient will just go. So these are some of the things. Then illness scripts and schemas. These are the risk factors, symptoms, and signs of diseases. You now want to go through the template. And that's why I presented the template. So that when I come here, I will just refer to it. But then I took 1 hour trying to do that. But I said, I'm happy that I did that because it was more realistic than just going through academic part that's just slides. So the illness scripts and schemas are the things that we looked at in that template. You're asking about the age of the patient, you're asking about the gender, you're asking about the alcohol intake, smoking, and all those things are now building towards you suspecting that there is a cardiovascular problem, there is a musculoskeletal problem. Then you now go through the history and you are asking questions. When did you get this problem? How did it start? What makes it worse? What makes it better? Then you now begin to say, oh, look, this category of condition is what is affected. Then you now go through the examination. You now say, okay, let me test for muscle power. Let me test for reflexes. Let me do spasticity. Let me do that. At the end of the day, you will now come to say, oh, look, there is motor problem. There is sensory problem from my assessment. And from my history, the patient was reported to have non-progressive brain injury or progressive brain injury. And therefore, my diagnosis is now going to be motor and sensory impairment in a patient that has non-progressive brain whatever. So this, you have reached your diagnosis at the end of the day. And you will see that that hypothesis from the basic mechanism of disease, the illness scripts or schemas will confirm whether it's the one or it's not the one. Because if from the examination I see reflexes higher, I see spasticity, I see this, I will rule out musculoskeletal, I rule in neurological. But if it's the other way around, then I'll rule out neurological and rule in musculoskeletal. Then the exemplars that are derived from experience is the issue of you treating a patient today, treating a patient tomorrow. I remember Professor Olaogun. Maybe it might not be good to mention his name, but the fact that he said this in public, and that's why I will just give this example. It was in a workshop that he told us, he said, I practiced long before I went to Kano. But he said, when I went to Kano, I saw a case of Guillain-Barré syndrome. And he said, because he had not been seeing that case in the Southwest, he had to now remember when he was in school and the articles he read about the symptoms and the signs when he was assessing the patient, and also thought back on the interventions given in those conditions. Maybe I would have added my words based on my understanding of exemplars. Might not be completely his words, but the concept, because it's long, I think more than 10 years that we had that workshop that he was saying this. What does that mean? With all his experience over the years, there is a condition that is not prevalent where he practices. After many years of practice, he goes to another region. When he sees that condition, he does not have experience of it. He still has to go back to basic mechanism of disease, come through illness scripts and schemas. Then when he sees 2, 3, 4, or 5 patients, the next patient that will come, instead of thinking of the books or the lectures or the articles that he read, he will now be remembering the last patient that he saw. He said, well, in that last patient that came, he had Guillain-Barré syndrome. And I saw A, B, C, D as symptoms. And therefore, in this patient, let me assess those symptoms and signs so that I will see if this patient also has Guillain-Barré syndrome. Because initially, from the basic mechanism of the disease, he would have hypothesized. Then his illness scripts and schemas, he will now be building his assessments. So you think of the books analytical. You use exemplars, non-analytical. What's the difference? My thought goes back to books. Exemplars, my thought goes back to the last patient or last 2 patients that I saw. And which one is it that makes you a better clinician? Exemplars. Even though the exemplars cannot be achieved without the illness scripts and schemas. Why is exemplars, what does it make you a better clinician? Because if you look at, what do they call this research, the name of the person, I can't remember, but that showed if you listen like you are listening to me now for 1 hour, they said you will retain not more than 15% of what has been said. But if someone teaches and show you visuals, maybe you return up to around 20-25%. But if you practice yourself after reading it, you do the hands-on. And then after the hands-on, you teach, you can return up to 90%. But the hands-on alone will give you retention of almost 70%. And that is why the exemplars, after reading the books, you apply on a patient, you continue to apply on a patient. At the end of the day, the exemplars will make you to retain more than 70%. And that makes you more of an expert than just using what you read in books and not apply. So someone like me, I haven't had the time to really stay in the clinic as much as I want to. Many of you listening to me now, when you go back to the clinic, you apply. Tomorrow you apply. At some point, I will come to the clinic. If they give me a patient and they give you a patient, you complete the process, do the right thing within 30 minutes. It will take me an hour before I complete the process. Because exemplars, they never lie. If you have the opportunity to stay in the clinic, see patient as over patient, patient over patient, there is no way, no matter how much knowledge someone has, that he will show you experience and expertise. They can never show you experience and expertise. So let me advise all of our colleagues that will sit down in offices and send interns to go and treat patients and come back and report to them. Believe me, in the next 5 years, that intern will have more experience and expertise than you. I have no doubt about that, because this is research that has shown all that. So possibly there are things that you'll show to that person, but there are other things that has to do with the hands talking that you will not. So maybe the wisdom, because clinical reasoning will come with a lot of what you see beyond what you touch. But when it comes to the skills in the hands, there's no way that someone that keeps touching the patient, that you will match their own expertise. So the basic science, experts give more coherent clinical explanations. Experts more selective in the use of data. Experts made more inferences. Experts use less basic science explanations. Traditional separation of basic. So experts give less basic science explanations. That's what is called encapsulation of knowledge. Encapsulation. I attend seminars, and when a question is asked, you will see deputy directors and research directors cannot answer. And one young intern will just stand up and be talking, and he will explain the thing beautifully. Everyone will clap, and he'll go out and say, see all these old people. They don't know anything. They can't even answer anything. But just go to the clinic and give a patient. What he said will just confuse him. Give him the patient, he doesn't know where to start from. But that person that he thought does not know anything because he didn't speak, he will just touch the patient like this, and he has finished. He knows what it is. The patient say, thank you so much. See, I feel better. This is what is called encapsulation of knowledge. You know the thing, but because you have been practicing it over and over, it becomes encapsulated. You can't say it, but it only comes through your hand, it touches the patient, and it does what it's supposed to do. So it's not about your ability to academically talk about things. It's about the brain sending it to your hand, not the brain sending it to your mouth. This is what we are after clinically, and that's what we'll be expecting. And therefore, if I don't get amazed that an intern speaks, academics, move aside. Let's go to the clinic, touch the patient. Has the patient gotten better? This is what clinical practice is all about. And this is what this issue of basic science is. Your ability to take that basic science information and apply it on a patient, not your ability to say it out to people. This is what matters the most. Let me be looking at my time, because I wouldn't want to go beyond the time that I've promised. So all this is about basic science, but I think I've explained the most important thing. Now, when it comes to formal knowledge of disease, this is looking at the illness scripts and schemas. Central knowledge for clinical practice, that's the central. And if you look at symptoms and signs of diseases, there's what is called semantic qualifiers. This is what shows expertise. When they say, come and present the case of this patient bedside in the lab, in the clinic or in the ward, and people will now hear you talking about this condition. The patient's symptoms started with sensory, it was proximal, and then it moved to distal, and it started affecting smaller joints before later it affected. It is recurrent, it's acute, it's chronic. They said the presentation of this patient is acute. They said, what do you mean acute? Because the patient, when they had the problem, it took only within hours or minutes to hours for the maximum symptoms to everyone knows. This one understands risk factors, symptoms, and signs of diseases. And this is what is called semantic qualifiers. It shows expertise and it shows something that relates clinically to verbally. You are making presentation that whoever hear you talk about that thing knows it's not from a textbook. Because you are talking about that patient that I've assessed. When I assessed, initially when the patient came, the sensation was oddly abnormal at the foot. But over 3 months, it now got to his knee, and then it continued up. You are thinking of a particular condition that has that presentation, you will now make that hypothesis. So these are called semantic qualifiers. So expertise is the product. What is the product that gives expertise? Illness scripts. If as a physiotherapist, I call a condition and I say, give me 10 to 20 clinical features of that condition. If you can't do that, there is a problem. You can't be an expert. Every condition, you must be able to say, in this patient, the patient presents with abnormal sensation, with this, with that, with muscle weakness, with atrophy, you need to mention as many as possible because these are the things that you are going to assess in the patient. Or when you finish your assessment, that is what you are going to use to say, well, what is the diagnostic criteria for this condition? This is the diagnostic criteria. Is that what I see in this patient? Yes, that's what I see in this patient. Then that is the condition that the patient has. So you don't know illness scripts? Go back and pick medical textbooks. They are not meant for medical students. They are meant for all health professionals. How I wish what I know now. I knew that in school. I used to go to the library very often, but I wouldn't know what to read. But if I go back to school right now, every single day I will pick one condition and I will read about its risk factors, symptoms, and signs. I will understand them and commit them to memory. So that when I go to the clinic, it is those risk factors, symptoms, and signs that I will keep asking the patient, do you have this? Do you have this? Do you have this? Do you have this? So that my assessment and questions is going to be like an expert journalist. You see them, Shun or whatever names in the channels or what TV station that everyone is talking about him. You see him with his laptop or iPad. He's looking at the questions that he has already predetermined he's going to ask the person. If he asks you a question and you begin to deviate, he will bring you back and say, no, that's not what I asked you. This is what I asked you. So our clerking in history taking, you just ask what happened. And the patient will now begin to give you a story. You know, my son is living in the UK. I wanted to go and visit him. And when I went to the airport, I was speaking to so person. I now missed step. All these issues of his son in the UK, he was discussing with someone. At the end, what you are after is that he missed a step. So let's just go to he missed a step and leave all the, but there is no way you can leave all those other things that are not important if you yourself don't even have a template of what to ask. So your illness script is important. The decision tree is what I explained to you. It's a tree. When the patient comes, you are thinking of every condition. But from your biodata, past medical history, family social history, drug history, you take a breath and you say, I suspect cardiovascular system and neurological system. Then what is your chief complaint? I have low back pain. I will add musculoskeletal to those three. So it's a tree. It starts wider and it is narrowing down. Then by the time you take the history, for each of the three systems that you have suspected, you get one category under that system. You are narrowing down. And then at the end, you now do your examination. You have three that you suspect. You say this is the impression. You send the patient to go and get a radiological investigation or to do another test. And when they come back from the test, you say, this is the condition. It is only one now that I've ruled in. I've ruled out every other thing. It's a tree. This is the decision tree. Understanding the decision tree adds to expertise. Symptom and disease probabilities. So this is the hypothesis. There's a probability that it could be a neurological problem or a musculoskeletal problem when a patient presents with a lower limb weakness and pain, as I've explained earlier. So this is coming from what? The basic knowledge of the disease. Semantic qualifiers. I've explained semantic qualifiers. I've also explained basic sciences earlier. All these things put together, your understanding of them is what makes you an expert. But of course, there's something missing. I should have added it, that issue of exemplars. You can know all these things. If you cannot be able to apply them on patient over time, you will still not be called an expert. So that is why comes below: experiential knowledge, exemplars, rapid retrieval of similar prior example without conscious awareness. You don't need to start thinking too much. No, that patient that came, that's what I did to them. Kit, you are finished. Done. Professor Owolabi, then Dr. Owolabi, I took a patient to him and I was sitting. This Oxford grading system that will take someone 10, 15 minutes. Just, okay, can you move my hand out, move it in, move it up? Before you know it, Professor Olabi, within 2-3 minutes, he has finished the whole Oxford grading system. When you go to a tailor, I go to tailors. One thing that impressed me about tailors is that if I am measuring someone, when I measure the shoulder, I will write it down. Then when I measure the hand or the leg, I'll write it down. But a tailor will do all the measurements and then he will now pick a paper. Maybe even before he pick the paper, he will talk to you and chat with you. Then he will pick a paper and you will now write everything down. That impresses me a lot. So the same thing with a clinician. If you do this thing over time, without conscious awareness, you are going to just do it within a short period and you have your diagnosis, you get into treatment. So these things are very, very important to take note of. So I'm not going to go into all these cognitive processes. I think I've explained the non-analytical, which comes after the analytical. So for an example, okay, maybe I will use a table to explain them. Analytical process consists of cognitive elements such as logic, critical thinking. This is a deliberate thing, is from reading things. While non-analytical is from doing what you have read over and over, that at the end of the day, you think of the last patient rather than the books or the lectures that you have listened to. Now, metacognition is another very important cognitive process. With metacognition, it's about while you are doing the things, how do you get feedback to be able to know if you had made an error so that you now correct it so that the process will be more perfect in the next process when you do it again. So let's say, for example, I've gone to see a physician. After seeing the last patient before I entered, he opened this compendium of medical whatever, and he was reading. Say, okay, why are you always reading? When a patient leaves, you read. So, well, the last patient that came, the symptoms and signs that I asked, there were 40 that I listed, but I only asked 20. When the patient left, I opened the book to see which of the other 20 I missed, so that when the next patient comes, instead of doing 20, I will do 25. That is metacognition. Or maybe a senior colleague, you do a clerking, you now present to the senior colleague and you said, why didn't you assess A, B, C, D? Oh, I forgot. And see, I read those things, but I did not practice them. The next time another patient comes, you will add those things. That is metacognition. You need feedback, either by yourself or someone giving you the feedback. Are very important. It's what makes the system to be perfect. So this is something important. You use non-analytical system, expert when diagnosing common conditions. So you diagnose common conditions that you have been seeing over and over, you make a clinical decision. That is what is called non-analytical process. But I should have started with analytical because it comes first. I don't know why I have it as number 2. So who uses analytical? A novice, a student, that's pre-service, or a novice during internship or NYSC. He goes for NYSC and he's the only person in the department. No one is going to guide him. What will he use? He will have to go back to his book, read, and then he will now come and do the assessment. Or the case of Prof that I mentioned earlier. He is an experienced person, but he went to a region that has conditions different from the ones that he sees. He must use analytical. But these are not good systems, because if you don't continue to do metacognition, that system is going to have a problem. Then another thing is that when you use the non-analytical and you never go back to analytical, what is going to happen is that if there is an update in the world, you are not going to use it in your practice. And that is why for 10, 20 years, you'll see some people using what they learned in school 20 years ago. Up till now, they are using it and they never advance. So what do you need to do? You do the non-analytical, but you now sit back and say, look, is there an updated way of doing things? I appreciate the fact that someone, who was it that asked me, sorry, I can't remember the name, but I appreciate the fact that you said, this is in my practice, I use backslap. Is it all right to continue using it? Can you see that you were using non-analytical, but now you're asking questions in a lecture. You are now getting analytical. Then you now make the decision. That's a better system than only using non-analytical all the time, without any metacognition. What I did to you was metacognition. You will go back and read more about it from the explanation that I've made. It's also analytical. So you have done non-analytical, you'll have add analytical, you make a decision. But what is a better system? A better system is when you use non-analytical through experience, you continue to read to add more to what you know analytically, then you do metacognition, then you make a decision. You now do metacognition again, then you continue with your non-analytical. That is a better system. It is what will give you expertise. That is an excellent one because it moves towards perfection. So I'm not going to go through all the slides. Let me see my time. Well, it's already at 30, but let's see from what we have done. What are the differences between an expert and a novice? An expert asks a series of questions. Patient's responses guide further questioning and planning of exam because he knows what to ask. He has a template. He has mastered illness scripts and schemas. He has mastered basic sciences, and therefore he owns the process. He is Imoni Amarere. He is shown in channels. They own it. That's why everyone is afraid of going to have an interview with them, because they own the process. The moment you are out of line, they bring you back out of line. Why? Because they know what questions to ask. They read a lot about current affairs. The moment you begin to talk about a law, they will read the law for you. If you are talking about what happened in America, they will give you the news because they have already read about it. But a novice is not even sure which questions to ask. They depend on the patient's history. And that is why they continue to follow them. They give them story for 30 minutes. At the end of the day, their clerking will only be 1 page. Expert uses semantic qualifiers. He'll be talking about chronic, acute, proximal, distal, because he knows illness scripts. Novice uses general terms. It started from the toes and then it continued to move up. It took 6 months before, but the use of chronic has completed everything for the expert. Illness scripts, he knows illness scripts. If you ask what are the symptoms and signs of this disease, he's going to list them to you. But the novice will not list them. Maybe he will just say 2 or 3 and that's it. And that is why he cannot be able to have a comprehensive clerking. The expert will compare and contrast alternative causes of diseases. He's saying that it's either a musculoskeletal problem, a neurological problem, for that patient to have lower limb problem. Now, how do I know? Let me do this test, reflexes. Let me do this. Let me do that. At the end of the day, he will compare and contrast. I will say, oh, no. See, this is neurological, not musculoskeletal. But the novice will only list possible causes and diagnosis, no contrast and compare. Memory of past cases. The expert has memory of past cases. He can be able to tell you that, do you remember that patient we saw last week? What do you think? It's similar to that patient. Don't you remember? He will be telling his students. But the novice, no experience or cases fail to be transferred to memory. Maybe he has seen it because he has not seen many. He has not transferred it to memory. Expert, faster, automatic. The example of Professor Owolawi in neurology that I told you in Kano, for those that practice in Kano, you'll know Dr. Owolawi. Is it Owolabi? No, Owolabi, the neurologist. I think he went to Saudi Arabia and he's back now practicing in Kano. Automatic process with common cases, slower, more deliberate method of testing hypothesis with all cases. That's what the novice does. Use of multiple abstract qualifiers for discussions. Poorly organized discussion, characterized by long memorized lists. So these are the differences between expert and novice. You can read about attributes of clinical reasoning here, criteria for expertise. How do you know that someone is an expert? I've explained a lot of this. Now with clinical decision making, I'm not going to go into that because of time, unless if you think we should take a little of it, but the clinical decision making, you can read about it. What's important is to look at the attributes of the task, the nature of the task, attributes of the decision maker, the person that makes the decision, the context in which the decision takes place. Now, if you remember, in neurology, and I think even in orthopedics, let me quickly share this picture, because that will be important in understanding this issue of clinical decision making. They will refer to many things like this. They said characteristics of the environment, nature of the task or the activity to be done, and the individual's characteristics or resources. These three things give rise to movement. So what we do is to only think of the task. Now, the individual, does he have cognitive problem? The example I gave earlier, if you want to do an activity, to train the patient to do activities, if they have cognitive problems, or they have lost a limb, they have amputation, the way you train them to do the activity or the task will be different from someone that does not have cognitive problem or that they have not lost a limb. The way you train an Ajebu that is in the urban area, sitting and playing with remote, will be different from the way that you are going to train a child in the village that will go out every day, play football and climb trees. The environment matters. The task you are going to give matters. The way you are going to train an officer that will sit in the office and write and sign checks will be different from the way that you are going to train or rehabilitate someone that is a driver, or someone that is a bricklayer. You train them differently. And therefore, for you to understand movement, you need to understand the environment where the movement will take place. You need to understand the task that is important to the patient or the individual, and you need to understand the characteristics of the individual himself. Their features within themselves, not the environment and not the activity that they're going to do. So this is really very important. If you understand that, then you will now be able to understand the slides on clinical decision making. And if you go through, you'll see some attributes, such as uniqueness. So extent to which features of the decision are unlike other decisions. So you keep seeing someone that has a particular condition. So for example, someone with back pain. Every back pain patient that comes, you are going to see them with pain that when they try to extend or flex, the pain increases. When you palpate to do digital compression test, the pain increases. But this patient now comes, no increase in pain when they move. Palpation does not increase the pain. So this uniqueness, what happens? Remember, that's when I said you will now start thinking of if there is any viscera, the urological system or any other system referring pain. So this is an attribute of the task that influences decision-making, uniqueness. Something comes, is not similar to the ones that you have been seeing. And therefore, the decision you are going to make will depend on understanding that uniqueness and that situation of the patient. Certainty, amount of information. You don't have knowledge of illness scripts and schemas. There are 40 risk factors, 40 clinical features. You can only remember 5. You take that 5. It will be very difficult to have certainty as to what the diagnosis is. But if there are 40 and you assess 30, 35, it will be easier to do an evaluation with more information to be able to say this is the diagnosis as opposed to this other one. So these are some of the attributes. As I've said, I'm not going to go through all of them. Importance, stability, urgency, familiarity, congruence, number of variables, relevance of variables, risk. So this is what shows you attributes that make clinical decisions relatively simple. When you are familiar with the situation, you have enough information that gives you certainty, there are limited variables, there's a stable situation, and there is congruence, and there's low risk. But what is it that makes clinical decision making to be difficult? Uncertainty. So these are the opposites of the other one. Then you have the nature of the decision making. And then you have the attributes of the decision making, capabilities, cognitive capabilities, metacognitive capabilities. I've talked about these things earlier, but they are just now trying to bring them. How do they influence your decision making? So now merging the clinical reasoning aspect with the decision making aspect. Then you now look at the context, the external environment. And that's what I was telling you with that diagram that I showed. You have seen task, you have seen the external environment or the external context. So I'm sorry that I had to rush through the clinical decision making part. I knew 3 hours will be difficult to cover everything. We usually have it on a Saturday from morning till evening, but unfortunately we were not able to have it last Saturday. We had to shift it to Wednesday, and it's only 3 hours. But as I've said, on the platform, if you want us to have 1 or 2 hours to discuss this further and also discuss more of the clinical decision making, I will be glad to do that without any payment from the participants. So I want to thank you so much for participating. If there's any question or comment, we can take them in a few minutes so that we can close before 11. So Dr. Jibril or Hafiz, please, over to you. Yes, Jibril or Hafiz, over to you. If there are hands, we take questions or comments. If there are none, you can give the final words and then we'll close. Yes, Mr. Muili. You can unmute and speak.
Thank you very much, sir, for this presentation. Anyone has question or comment or contribution can go ahead with it.
Yeah.
Thank you.
Thank you, Prof. Thank you for the lecture, sir. What I just want to say is that the clinical table and the clinical decision table you made mention earlier before the adoption, can we have it on the platform so that we can start training ourselves based on the information you gave us earlier, sir?
Yes, I'm going to send the slides, that template for assessment, and any other material that I've used to Hafiz will share. Or maybe I will share directly on the platform since I'm on the platform. I'm going to share them immediately we close this session.
All right, sir. Thank you, sir.
Anyone with another question or comment or contribution? So in the absence of any contribution or question, now we can say goodbye to you all. Good night. Have a peaceful night rest.
Good night, everyone.
All right. Good night, Prof. Thank you so much for the lecture.
Thank you. Sorry, please, we usually have challenge with certificates. You should do something about it, please. Some of us have not received certificates of past lectures.
Okay, sir. It will be noted. Thank you for this comment. Thank you very much.
There's a question we have to ask, but probably by next time we'll be able to ask those questions as regards to the license.
Good.
Regards to license renewal.
Yes, I think issue of license renewal, we can discuss them on MRTB platform. So maybe if you make a request for a meeting, I can oblige and we set a time to meet. If not, maybe personally send a message through WhatsApp or send the message through any of the MRTB platforms.
Yes, actually, I was trying to even call. I tried to call you, but you were not responding to the call.
That's
It's
why I say
just that
WhatsApp. Because you can see how it is from morning. I've been having a meeting from morning till 7. So immediately after the meeting, I had to rush home and then pray, and then I started this meeting. So from 9 in the morning until now, I've not had 1 hour to rest. So it's difficult sometimes to pick calls, but if you send a WhatsApp message at my free time, I will respond. Or if you request for any meeting on MMRTB platforms, and
I wouldn't know whether that is actually I wouldn't know whether that is the actual contact that I have, but it was a challenging experience for us that we could not reach out, and most of those officers that we have in contact with.
Please get my phone number. If you send me a WhatsApp message, if it's not the one, you can ask any colleague to collect the number and send me a WhatsApp message. I will respond.
Okay, sir. Thank you, sir.
Thank you. Well done.
So thank you all. Goodbye. Good. Thank you very much, sir. Appreciate it.
Thank you. Good night.
Good night. Thank you.
Thank you, sir. Good night.